Good evening, everybody, and welcome to this evening zero COVID Coalition meeting on why we need a people's vaccine and the fight for vaccine equality. As the UK rolls out our vaccine, and we see countries in the global north doing that, and praising the efficacy of it and praising just how well they are at getting to the entire population, we see a completely skewed situation right across the world. Now, this is a global pandemic, and you would think that a global pandemic would require global response. Instead, a lot of the money that has been used, and public money, I might add, definitely in this country, to produce the coronavirus vaccines went into private companies and now being made for profit. We are in a really dangerous situation right now where right across the world, we are seeing countries that will not be properly vaccinated for another couple of years. And even if people completely lacked compassion, we would hope that they didn't lack common sense. As a global pandemic, the longer we leave it for everybody to be vaccinated, the longer it will be until we are all safe. And you may have heard people use the very common phrase that no one is safe until we are all safe. And in a global pandemic, this counts for everybody across the world. Now, tonight, we're going to be hearing from a fantastic range of speakers, and they're going to be very disciplined and keep to time. And we are so pleased to have them with us. For those who want to use social media to comment or publicize the meeting, the suggested hashtag is going to be #4 people's vaccine. And for those who want to keep up to date with our campaigning activity, please follow us on Twitter, go to our Facebook page, to our webpage, to our YouTube channel. All of these things will be flying into the chat as we go along. Now, some of you have noticed that the meeting is co-sponsored by the Zero COVID Alliance, which is an alliance of 30 different groups operating out of more than a dozen countries, and it brings together campaigns for zero COVID, for a people's vaccine, and around many issues of inequalities thrown up during the pandemic, as well as the issue of long COVID. And we're delighted to be working with them and hope to deepen our collaboration in the future. So, before we hear from our first live speaker, here's a short video from one of our co-founders of the Zero COVID Coalition, Diane Abbott Mp.
Thank you all for coming to this meeting this evening. We have a great lineup of speakers, and I'm looking forward to hearing them all. Unfortunately, I can't be here in person this evening as I am double or even triple booked for meetings and media appearances this evening. But I will be catching up with the meeting online later. The issue of vaccine equity and the importance of a people's vaccine is very serious. We can debate the role of vaccines. Scientists can try to establish precisely how effective they are. This is all important work. But for vast parts of the world's populations, these debates and inquiries are almost entirely academic. The UN tells us that by April of this year, just 2 of every 1,000 vaccines distributed in the world have gone to low-income countries. There is a risk that protection against the virus becomes a privilege of the rich countries. We have seen this happen with other deadly diseases. It is wrong, and it must not be repeated with COVID-19. And at the same time, many of the richer countries in the world are blocking vaccine patent waivers at the WTO. Joe Biden has done a U-turn on this and now wants the patent suspended, at least for the duration of the pandemic. That's good news. But all the Western countries that host big pharma companies should do the same. The French, the Germans, the Benelux countries, Scandinavia, and Britain itself. Public health around the world is far more important than the profits of big pharma, and we must all hold our governments to account on this. Finally, there's the issue of vaccine fairness within our countries and the importance of not excluding already marginalised communities. That is a real challenge in the current political climate. I hope you have a great meeting this evening. I know that this work will need to continue, and I look forward to eventually catching up with all you have to say. Thank you to all the people who helped me put this meeting together. Thank you all for attending, and I look forward to seeing you all again soon.
Thank you very much, Diane. Thank you. So we're going to go straight to our next speaker, well, rather our first live speaker of the evening, and he is Dr. Masaka Fala. Dr. Fala is a world expert on epidemiology who's worked with a series of international bodies on the Ebola and HIV crisis. He has studied and worked in the US, including Harvard, and has helped to establish public health bodies in both Liberia and in the DRC, and continues to campaign for vaccine equity globally. Dr. Fala. Oh. Okay, I don't think we have Dr. Fala just yet, either that or there is a technical hitch. And we know that happens all the time on this wonderful world of Zoom. So we're going to go straight to our next speaker, who is Richard Horton, and he is the editor-in-chief of The Lancet. Richard's spoken at our meetings previously, and we're delighted to have him return. Richard's going to provide his analysis of the current situation here in the UK and how that fits into the global pattern of the virus spread and vaccine distribution. Richard.
Well, thanks very much indeed, Belle. I hope you can all hear me okay. You know, despite the euphoria as we approach the 21st of June and the increasingly optimistic statements that are being made by government ministers, and even, I'm sorry to say, some scientists, we're actually at an extremely dangerous moment in the pandemic. In particular, vaccine nationalism really risks turning a potential triumph into tragedy. First thing to say is that the numbers that you see reported are incorrect. They are huge underestimates. WHO reports 3.5 million deaths worldwide, but even they and others now recognize that a much more likely figure is well over 7 million deaths worldwide, more than double, in fact. And the projection is that by the 1st of September, just a few months away, there will be an additional 1.8 million deaths. So anybody who tells you that the pandemic is on its way out is just simply wrong. It is true that the pandemic worldwide is slowly in decline. The cases are down from around 11 million per day to about 6 million per day now, and deaths are stabilizing at around 30,000 per day and are projected to decline to around 12,000 per day by early August. But it's very important to still remember that COVID-19 remains the #1 cause of death worldwide, and we can expect deaths to begin to increase again in August. The situation in India and Brazil, even Japan, remains extremely serious. And although we're seeing declines in numbers of cases across North America and Europe, reversal is possible if we release mandates too quickly or if B1617 infection escalates. It's very important to remind ourselves that R is greater than 1 in many countries across Latin America, Asia, and Southern Africa. And between now and September, around 40 countries in the world are expected to see significant stress on their intensive care systems. So that's the situation today, perilous. But surely you could ask, vaccination is going to pull us out of this global crisis. And it is true that an incredible 1.6 billion doses of vaccine have been delivered worldwide. And by September, we should have vaccinated with at least one dose of vaccine over 3 billion people. But the fact remains that if you look at countries throughout the world, 127 nations have less than 10% of their population fully vaccinated, which leaves a phenomenal number of people still at risk. Now, COVAX, led by WHO, UNICEF and others, is supposed to have fixed this problem. It's supposed to have been the groundbreaking collaboration that will deliver equitable access to treatments and vaccines. And its goal was to procure 1.8 billion doses of vaccine for 92 low-income countries by the end of this year. And that would protect half the adult population if that was achieved. But so far, only 69 million doses have been distributed. Remember, the goal is 1.8 billion, but they've only distributed 69 million doses. And India's Serum Institute, which is supposed to supply a third of COVAX's needs, has understandably said that the crisis in India means that they can no longer supply vaccine to COVAX until next year. Remember also that some groups, and I'm thinking particularly of 46 million refugees, internally displaced people, migrants, and asylum seekers, are largely excluded from national and global vaccine programs. So what's to be done? What's to be done? We need to collaborate with other high-income countries to expand healthcare capacity through donations of ventilators, PPE, tests, medicines. We need to expand vaccine access, releasing surplus vaccine stockpiles, waiving intellectual property rights, lifting impediments to raw materials, supporting technology transfer. I saw at the weekend Gordon Brown's call to the G7 to underwrite 2/3 of the costs for this kind of work. That would mean for the UK providing about 6% of 66 billion US dollars. We need to scale up lab testing and genomic sequences in countries, provide technical assistance and training for health providers, making sure that there are logistics in place to support transport of resources, making sure global supply chains are working, strengthening surveillance systems, and making sure that data is available for accurate decision making. And finally, we need to support the recommendations of the Independent Panel on Pandemic Preparedness, one of their most important recommendations being the creation of an independent pandemic financing facility providing between $5 and $10 billion a year for countries to draw on to strengthen their global health security. But in the medium term, I've also argued before that we can only control this pandemic by treating it as a syndemic, a synthesis of epidemics. It's a virus, yes, but it's a virus whose effects are cruelly amplified by both pre-existing poor health amongst our communities and worsening inequalities. It will be essential for governments to usher in a new era of health promotion and policies to defeat inequality, aspects of the response that our current government is currently utterly silent on. I saw writing in the Mail on Sunday yesterday, Jonathan Sumption asked whether the Prime Minister will stand up to the public health bullies, in his words, or as he also called them, these health fascists. But these so-called bullies, these so-called health fascists, are concerned that the over 200,000 deaths from COVID-19 in the UK, and that's the likely figure, not the 127,000 that's often reported, were not only mostly preventable, which they were, but also could be significantly added to if we don't take a more careful approach. Even in the most vaccinated nations, the pandemic is not yet over, and we must all remain acutely vigilant. Thanks, Val.
Thank you very much, Richard, and thank you so much for your continued support. So we're going to move on to our next speaker, and continuing on with speakers that really do represent the international view of the work that of the Global Vaccine Alliance and the Zero COVID Coalition right across the world. We're delighted to have from Medicines Sans Frontiers, Wang Hu, who is a senior legal advisor to Medicines Sans Frontiers with a focus on medicines and intellectual property and working across multiple jurisdictions, as I explained. And she's going to share with us some of her expertise, her global expertise on what is at stake in the fight over patent waivers.
Thank you very much. It's my pleasure to share some of our work in Medicines Sans Frontiers, Doctors Without Borders with you. So I will start actually by sharing what we have been doing in MSF in developing countries, and when exactly echoing Richard mentioning, if anybody says pandemic is going to end, we strongly disagree, because our staff and our team are still struggling and our patients has no access so far. So since last year, MSF has been responding to COVID-19 in more than 70 countries. Most of them are developing countries, because we are facing triple tasks, not only for vaccine, for COVID-19, but we also try our best to maintain essential health care services for a population who are normally not in the formal healthcare system. Marginalized population, people on the move, refugees and internal displaced peoples, they are not only not getting the normal healthcare, they are at the last in the queue to get COVID-19 vaccines and other medical tools. So our team has been repurposing the existing facilities in Iraq, in Haiti, in Lebanon, increasing our response now in India, Brazil, and soon in Nepal when cases are rising. And also we are facing challenges to secure on a daily basis the supply and protection for frontline workers. So when we talk about vaccine, which is essential to end this pandemic, we're also facing challenges to secure access to even the basic protection facilities, ventilators, oxygens. These are the daily struggle for people who are continue getting sick in those countries when cases continue to rise. There's a supply shortage of treatments, even we know therapeutics are very limited in terms of efficacy, but there are some drugs that need to be used and the supply is in shortage. Some of them are because of the monopoly, such as remdesivir, and some of the new pipeline therapeutics are no access guarantee inside, basically. And then we remain having the challenge to maintain essential healthcare services. Some of our facilities has been closed. And then we have experienced and calculated not only access challenges between countries, but within country and among populations. For instance, our project has observed it's over 16 times more likely to have a vaccination in Israel than in Palestine because of the inequality of distribution, and also because of the root cause when we have the significant gap in global production and supply. So for all of this reason, it's compared MSF to really engage in a discussion about how to remove all of the monopoly and barriers to production and supply so that we can have the assurance of global access. So some of the actors and the pharmaceutical company claim, especially for vaccine, by saying that there's no problem with IP. The problem is raw material supply. It's because the developing country cannot produce. And we have repeatedly disagree and showing evidence proven the contrary. For very long periods of time, MSF have been hearing this kind of argument over and over again. Whenever there's new technology come to the world, the pharma always said it's so complex, only us who can do, and developing country just wait. And so this argument come back again. And we have seen evidence there are producers in developing countries who are saying that we are ready, we can wrap up. If we have no legal risk, if we have access to technology and know-how, we can immediately start preparing. And maybe in a few months' time, especially for newer technologies such as mRNA, which scientists told us it requires less time to prepare, easier to scale up, cheaper to produce. And the pharma told us the contrary. They said it's super complicated, it's very expensive, only us can do it. So for this reason, we basically are saying a contradictory argument led by the pharma and echoed by some of the high-income countries in this debate of removing IP monopoly at the WTO. So our evidence is showing that there's hundreds and hundreds of patents already attached to COVID vaccine in order to remove those barriers to allow global production and diversify of supply. The legal barrier has to be removed by adopting the TRIPS waiver that allow country to move very quickly. We already see examples such as Russia, who issued the compost license on the COVID-19 treatment, but got sued by a pharmaceutical company. And this lawsuit also prevented Russia to quickly help India with the generic medicine they produce. So all of this evidence leading to us to the core really, with the US changing the position, many countries joined the suit. It's very imperative for all countries to get behind this proposal. And also it's very essential for us to realize that because the COVID situation is still increasing in many developed countries, the proposal needs to cover not only vaccine, but also treatment and diagnostics and the raw materials that are needed to produce them, so that us, especially from the perspective of medical professions, we will have all of the tools needed to help people to end this pandemic together. So I will stop here and look forward for the discussion. Thank you very much.
Thank you very much, Juan. I find myself nodding along so much because it's just completely disgraceful how big pharma are controlling this situation. UNICEF has actually estimated that the volume of output could be as much as 20 billion in terms of vaccine, and the total manufacturing capacity of Pfizer, Moderna, and AstraZeneca combined is only 3.2 billion. And we know that there's huge manufacturing capacity in countries like India, China, Brazil, Mexico, South Africa. So the scarcity of supply, as you've rightly stated, is completely artificial, but there seems to be no scarcity of greed. And that's what's holding people back from being vaccinated globally. So thank you so much for that. Our next speaker is Dr. Jeremy Rossman. He is one of our scientific speakers and a senior lecturer in Kent and the president of Research Aid Networks. Jeremy is also an advocate for zero COVID and a people's vaccine, and he will also be able to tell us something about the situation in the United States, in keeping with our international theme, where President Biden has actually done a U-turn and unlike our own government is no longer opposing vaccine patent waivers. Dr. Rossman.
Thank you very much. It's my pleasure to be here and talking about the scientific case for vaccine equity, because vaccines are one of the best tools that we have in slowing the spread of COVID and preventing people from suffering from severe and fatal cases of COVID. So this is one of the best tools that we have. And yet, when you look globally, the majority of the vaccine doses that have been distributed have gone already only to a very small subset of countries. This leaves broad areas of the world with very low vaccine coverage. And of course, this is a problem if you think about our ethical and moral responsibilities to each other. But this is also a problem even if you take a more self-centric and country-specific framework, because this global vaccine inequity also plays an impact even on countries that have very good vaccine coverage. And the reason for this is that every time the virus infects another person, it changes a little bit. And so the more people you have infected, the more cases and the more spread of the virus, the more mutations you get, the more variants that you get arising. And we've seen this over the course of the pandemic of seeing more and more variants of this virus. Some of these variants start to transmit more. Some of these variants start to evade the vaccine protected immunity. And so the longer we have this global transmission of the virus, the more chances of a variant emerging that can actually evade the protection of the vaccine. And so even if you had a country that had 100% vaccine coverage today, this continued transmission and mutation of the virus around the world will still put them at risk in the future. Now, I know this is a brand new virus, and this seems like a completely new and novel situation that we're getting into and trying to figure this out on the fly. But in fact, when we look at a more historic framework, well, vaccine equity and this sort of inequitable distribution across the world is nothing new. Because in 2009, we had the H1N1 swine flu pandemic. And during that pandemic, we saw exactly the same thing that we're seeing right now, this vaccine nationalism, a limited number of countries pre-ordering the majority of vaccine doses in the world. Now, we also had efforts trying to address this with the WHO and UN appeals for donations, increasing supply, distribution, and funding. And that was helpful. But the donations were also limited to the availability and what the very select few countries were willing to do. And so when you had slowdowns in manufacturing, many countries then reprioritized their own distribution again. And so there were no fixed delivery dates. There was no process for ensuring that global distribution on any time frame. Now, because of this, there was a lot of talk of what we could do, this idea of having a global access framework, a real system that would allow these vaccines to get around the world. But this was designed with very flu-centric proposals. The idea was that we thought the most likely thing to happen was going to be a flu pandemic. But that's not exactly what happened. And importantly, all of these ideas were not legally binding. So they were sort of best practices, recommendations for what countries around the world could do. But it was not legally binding, and so didn't often happen. Now, it seems like we're in exactly the same situation, but in fact, there is improvement. And so an example is what we've been hearing about in the US recently. And this is where the US has recently come out with support for the patent waiver. Now, this is a really positive step with the US sort of getting out of the way of this patent waiver, but it's a strong difference from the US being a firm sponsor of this and really pushing it forward, because a lot of the language is that they will engage in discussion and not necessarily definitively push it forward. And this is all occurring in the context of the US still prioritizing their own vaccine schedule. This comes out after the US had enough vaccine doses to really vaccinate their entire population. So this is still a prioritized response. Now, the US has also done a lot of other good things. I mean, they are contributing doses of AstraZeneca vaccine. They have been the largest contributor to COVAX funding. They have contributed to manufacturing export of tools, resources, and technology, and have been developing partnerships and tech transfer. And all of these components are essential to go with this patent waiver, because while the patent waiver is great for helping to enable more manufacturing and supply, what we need to be looking at is how all of this works together, how we get the expertise, the equipment, the supplies, storage, transportation, and of course, the critical funding for this to occur in countries around the world. Now, there are a lot of different models. We have the WHO mRNA tech transfer hub and spoke model. We have the COVAX distribution and funding system, and we have the World Health Organization fair allocation model designed to get 20% vaccine doses to all countries, and then to prioritize vaccine supplies to countries that really need it to support the vulnerable population. And these are all great steps. But of course, that fair allocation model is dependent upon the definition of the vulnerable population. And that's based on severe COVID infection, but actually ignores the fact that even healthy young adults that are not in a vulnerable population can get and suffer from long-term illness of long COVID. And so together, we also need to remember that this is not a one-time thing. We don't need to just get 2 vaccine doses out to the world and then stop. We need to be able to manufacture variant vaccines, potentially boosters, and then to maintain that funding and supply to ensure that the world continues to be protected. So this is a very involved process. We are at the early stages. We have great vaccines, and we have some models and ideas for how to do this. And hopefully we will continue successfully down that road. So with that, I would just like to thank all the affiliated organizations and for your time. So thank you.
Thank you very much, Dr. Rossman. And we're really pleased that we do have Masaka Fala now on the call. Are you, Masaka, sorry, are you able to contribute now?
Yes, thank you very much.
Fantastic, thank you.
Listening to Rossman speak on the issue of how do we prioritize vaccine. A few minutes ago, I spoke to a colleague of mine who is in Canada and has a relative in India. And he said that the trend of the outbreak in India has become very unusual for the fact that most of the young people are now dying from the COVID, and that interestingly, most of these young people are asymptomatic. They walk around healthily, and all of a sudden, they develop severe hypoxia and died. That just reinforced the fact that we're dealing with a virus that is mutating very rapidly. And the risk factor we know today will change by tomorrow. We do know now there are instances where certain variants cannot be diagnosed by the conventional PCR measure. All of these are reinforcing the fact that it has to be, we have to see this from a more global security point of view. I know I come from Africa, and many presidents, I was in the last debate, and they spoke about charity. I said, no, this is not about charity. This is about our survival as human being, human population. Except the developed nation decide to live as island and decide not to communicate or interact with the rest of the world. But as long as we're going to interact with the rest of the world, there's going to be movement of people, goods. There's no way one group of the world can be left vulnerable because the virus will continue to mutate. And I would want to speak on India and Africa simply. Africa, like India, when the COVID started, went on massive public health lockdown. Some of the measures were draconian. The airport was shut down, international travel shut down. I was part of that movement, and Africa did a great job. But what is happening now is that because of the inability to test effectively in almost all of the African countries, there is now a false sense of security. No one is testing except for travelers. And we all do know the virus is in Africa. It is mutating, it is spreading. People are celebrating having political rallies like it happened in India a few months ago. The saddest thing is that every day I go to bed, what keeps me awake is that whatever happens in India happens to Africa. And why should it not happen to Africa? When people are meeting in large groups, when there are no testing going on, when there is a broken health system in almost all of these countries, why should Africa not be affected? When my greatest worry is that when Africa is affected, it will be the greatest human calamity we've ever seen, because Africa has less than 1% of all of the vaccines. Very few persons in Africa has been immunized and vaccinated. And so imagine having a broken health system, limited testing going, limited ability to do sequencing to know the extent of the variant that are spreading in the community. Every day, planes are traveling from Europe and the US to Africa, India, and the rest of the world. Every single passenger on that plane has a propensity to spread the variant, yet Africa has less than 1% of the vaccine. So we sit on a time bomb that we must resolve. From a moral, ethical point of view, we realize that vaccine is critical. Even when the US government under President Biden made the statement towards the RP waiver, I was shocked to see that many scientists like us gave all the reason why there should be no vaccine waiver, that waiving vaccine will disincentivize research and development in future outbreak. We are speaking about it now and here. How long can we sustain this outbreak without immunizing everyone? What we have been taught from Ebola is that the neglected spot of the world becomes the hotspot of tomorrow. And so this is a bigger argument that we have to see, that for global security, there has to be a mechanism. And there are a couple of things that we can do. The issue that vaccine raw material is being stockpiled is being held by a few countries. The fact that countries have enough vaccine to vaccinate a single person 3-4 times. I can walk in any store and decide what can is to distribute the vaccine for our own security, for our own economies that have to survive. And like I say in conclusion, every day I go to bed and I worry that what happens to India, happen to Africa. Less than 1% vaccine, sequencing ability. We are going to live with this on our consciences for the rest of our survival human beings if this was to happen under this condition, because Africa will be wiped out, the continent will collapse. But more besides, from a multiple security point of view, as long as human beings are moving, no part of the world is safe. So we need some practical solutions, like the RP pushing for the RP waiver, the technology transfer, countries with the excess vaccine dose to tend to give them away. The WHO Director General said he needs $19 billion to support COVAX. That's a minimum we can start with, putting funding into COVAX to ramp up the distribution of the vaccine. It is about humanity. It is about survival as a people and as a race, that we must invest in the vaccine and ensure that our maximum security is the security for all with vaccine equity and access.
Thank you very much, Masaka. Thank you so much for joining us today. So we are going to go on now to our next speaker. We're doing quite well for time, which I'm very pleased. Thank you so much to all of our speakers, not only for your fantastic contributions, but for making my job as chair quite easy. So our final actual scientific speaker is going to be Jade Khalif, who's an expert in health system and hospital performance. Jade is currently leading the development and implementation of hospital performance-based contracting in Lebanon of over 140 hospitals and the Lebanese Ministry of Public Health. He's also one of the founders of Zero COVID Lebanon. The movement is global. And Jade will be speaking about the specific duties of public health care during the pandemic in the Lebanon and other countries outside rich Western ones. Jade.
Thank you, Val. It's a pleasure to be here with you all. I have three main messages in my small contribution today. The first is inequity across countries exacerbates inequity within countries. The second is commercialization can increase inequity, whether or not it's linked to profit. And the third one is inequity harms everyone's health, including the most vulnerable. So we see vaccine inequity unfolding both across and within countries. And it's important to recognize that global inequity also exacerbates inequity within countries. We have a limited quantity of vaccines in the world today, and most of the supply is concentrated in the global north. But the problem isn't just that there is a limited supply to the global south, but also an equitable distribution of vaccines within some countries. Already, several have opened up to the private sector importation and or sale of COVID-19 vaccines, such as some examples like Colombia, Indonesia, India, Kenya on and off, Pakistan, the Philippines, and recently also Lebanon. So there are some organizations like Transparency International and others that have been voicing their concerns regarding inequity. I'll briefly share our experience in Lebanon, where the private sector has also been engaged. As some of you may know, Lebanon is a small country in the eastern Mediterranean region with about 7 million people, a quarter of which are refugees. We've been having an exceptionally painful time with an ongoing and overlapping political, financial, and economic crisis. So today this means about 40% unemployment and over half of the population living in poverty. The first 6 months of the COVID crisis were handled relatively well because a containment approach was used. That helped save a lot of lives. Going into the summer of last year, we had less than 30 deaths at that time, and very limited spread, despite widespread testing at the time, which was also a challenge to set up. But after that, we shifted into a failed mitigation approach, a weak mitigation approach, and that led us up to the catastrophe that we had between Christmas and New Year's, where the country was opened up, and it resulted in over a third of the population being infected and much death. So it was fundamentally a very inequitable strategy to begin with, and only the better off groups within society could distance more than others. Right now, we've only recently reached the pre-Christmas levels, but the overall approach is still relying or over-relying on vaccination. Vaccination is very important, but it's only began 3 months ago at a very slow pace in Lebanon. We have less than 4% of the population fully vaccinated. We have priority groups that have been defined by the health ministry according to age and comorbidities. But of course, we suffered massively from global vaccine inequity, as well as the state being essentially bankrupt. So we've had several private actors that were allowed to purchase and or deliver COVID-19 vaccines. Now, collaboration between the public and private sector can be useful in areas where the public coverage or the reach of the public sector is insufficient or more limited. But much of what we're seeing in Lebanon is weakly regulated. This is resulting in slower vaccine delivery to the most vulnerable, as well as commercialization and profit by some private actors. So the private sector is not subject to the national priority groups. So we're seeing images every day of 20-year-olds with no comorbidities, no chronic conditions. They are being vaccinated before some 60-year-olds, simply because they happen to be an employee of a certain company. More resourceful companies, as well as some unions, some syndicates, have been able to secure faster access to vaccines than the rest of the public. One could argue that they may be not to blame so much, especially if they are not making profit out of this, which is also something challenging to really be sure of in some cases. But especially in a situation where we have a vastly weakened central state. But it doesn't change the fact that the inequity is increased. At one point, we even had a minister pushing to prioritize vaccination of journalists. We also had the national airlines, employees of the national airlines and the banking association prioritized through this private sector mechanism. It also has expanded to politicians engaging in clientelism, unfortunately, and bypassing the state to purchase and vaccinate their own supporters or regions where they traditionally enjoy greater support. We've had already several examples unfolding, and we also have elections coming up in less than a year or so. So you can connect the dots. Other inequities include some politicians skipping the vaccination line. In one very publicized case, we had some members of parliament, a handful, vaccinated before most of the priority groups. They basically skipped right to the start of the line. And when this was uncovered, the excuse was that they were being rewarded for their hard work on speeding up the regulations required for the purchase of the vaccines. That is certainly a very bad example. We also have a slow vaccine delivery to refugees and migrant workers. Even their registration within the national platform was also delayed and problematic. So there's been several barriers also to do with that. And when you think that's about a quarter of the population, it's quite a massive challenge. Well, most of the vaccines delivered so far have been among the more effective ones. We also have instances where less effective vaccines are being given or planned to be given to some groups. And these, most of these were a donation, which is something to be thankful for from other countries. But it also raises the question of why some vulnerable groups should receive less effective vaccines while other better off groups don't or receive better, more effective vaccines. So this obviously makes it harder to reach a higher level of population and a higher level of population immunity. So in effect, it's not only the vulnerable who suffer, but all of society, and more downstream, since we're all connected, the world. So entering the pandemic age means that ensuring sufficient vaccine supplies has become an important strategic issue for countries. And if they can't access them or develop them, the inequities will continue, perhaps expand, and we'd be failing at improving global health, since after all, the goal of health systems is not only to improve health overall, but also to improve health equity. Thank you.
Thank you very much, Jade. Thank you so much for joining us. And again, another speaker who's keeping us very well onto time. So our next speaker is going to be Heidi Chow, here to explain what is meant by a people's vaccine and to outline for us how the international campaign is developing and all the challenges it's facing. She's representing the People's Vaccine Alliance and is a senior policy manager at Global Justice Now, fantastic organisation. Heidi will be able to tell us about the involvement of both groups in the international campaign. Heidi.
Thank you, Belle, and thank you to Zero COVID for organising this event this evening. It's been brilliant to hear so many amazing speakers. So over the last few months in the UK, we've seen the important role that vaccines plays in terms of enabling the gradual unlocking of our economy and lifting of social restrictions. COVID-19 vaccines were always going to be an important part of how we are going to end this pandemic. And from the start, they should have been treated as global public goods. And in a sense, they already are. They already are the people's vaccines, because all of them have had billions of dollars of public funding poured into them. Public funding paid for research and development. It's paid for at-risk manufacturing. Governments have even offered corporations indemnity from liability if things go wrong. And of course, it's the public that have put their bodies on the line to test these vaccines for us all. And so instead of having a people's vaccine, these vaccines have been privatized by a handful of corporations and turned into private assets for profiteering, which has led to the scarcity of supply that we've talked about already this evening. And also the amounts that have been produced have been hoarded by rich countries. So now we have these grotesque levels of inequality. Rich countries like the US and the UK have hoarded enough doses to vaccinate their populations almost 3 times over. And we are on track to vaccinate our adult population by this year. Meanwhile, countries in the global south could be waiting up to 2023 or even 2024 for widespread vaccination. And only 0.3%, and that's less than 0.5% of global vaccinations have taken place in low-income countries. Last week, I gave oral evidence to the all-party parliamentary group on coronavirus at a hearing that they organised on vaccines. And one of the questions they asked me was, how do countries in the global south look at our national vaccine rollout programme here in the UK? And I had to ask a friend and an ally, Fatima Hassan from South Africa, and Achal Prahabla from India, to give me a quote for the hearing, because I didn't feel equipped to be able to answer that question on their behalf. And so I wanted to bring their voices to our MPs. And so I wanted to share with you the quotes that they gave me. And so Fatima Hassan from South Africa said, "We can't travel to the UK, you can come here. It's different because you are mostly vaccinated. We have only just started. Yesterday, Archbishop Tutu got his jab months after young, healthy people in the UK. Why? Ask yourself why. We have limited vaccines. The UK's stance on intellectual property, hoarding, and overbuying has meant that someone over the age of 80 in South Africa has only just got his vaccine on the 18th of May. Also, we took part in the AstraZeneca trial, the Johnson & Johnson, the Pfizer, and others, yet we are not guaranteed access. So much for the Commonwealth." And then Achal, who's based in India, said, "One of the most striking things about the last month is just how many people I've lost and how many people every single person I know has. There is literally no exception. Everyone I know is in a perpetual state of panic as to who is next. It's like a culling of the elderly and the vulnerable. It's just pure hell. But also, we dread to think what will happen next. I've been talking to the African Union's African Vaccine Delivery Alliance, and they said we're at the point where we're rearranging deck chairs on the Titanic. The closest prospect that the African Union has to getting any vaccines, any at all, is from Johnson & Johnson in August, a whole 3 months away, and we have no idea if they'll even keep to that schedule. With COVAX supplies pushed out almost indefinitely, there's literally no solution in sight." And I wanted to share with you these quotes because for me, they highlight the very real impact of vaccine inequality for people who are facing the second and third waves of this pandemic completely unprotected. And just like in the HIV/AIDS crisis 20, 30 years ago, this is not just an issue about access to vaccines, but it's also about racial justice, because it's the lives of Black and brown communities in the global South that are being sacrificed at the altar of corporate profiteering. Now, we are in this situation because of monopolies on vaccines. These are monopolies that are created by intellectual property rules that were written by the industry themselves over 2 decades ago. And so once a vaccine or a treatment has a patent, no one else can legally make it. And since that time, when these rules were written into this global trade agreement, public health needs have taken a back seat to these rules, whether it's access to medicines for HIV or cancer or cystic fibrosis. These rules have put monopolies before saving lives. And now we're in the middle of a pandemic where there aren't even enough vaccines for all countries. And there are manufacturers across the world who've said they are ready and able to make vaccines to help global efforts, but they can't because of the intellectual property barriers and because companies are not sharing their technology and their know-how. So based on People's Vaccine Research, last week we launched a story of some research which showed that this monopoly system has created 9 new billionaires with a combined wealth of $19 billion that could pay for vaccines for every person in low-income countries. But these billionaires have been created by the same monopolies that are also restricting supply, leaving billions of people without access to any doses. So the only way to ensure that we have enough doses to have enough vaccines for every country is to break up these monopolies. So that's why we are fighting for governments to support the proposal to suspend intellectual property rules. We've already heard this evening that the Biden administration has announced its support for this proposal earlier this month, and that's going to help shift some of the global politics on this proposal. But countries like the UK and the EU are still standing opposed. And it's not just the intellectual property. We also need to force companies to share their technology and their know-how through the World Health Organization. And the People's Vaccine is also making demands for public investment to build local and regional production capacity in the global South, to essentially redistribute power in the global system and put public health and export access back in the driving seat. The movement for a People's Vaccine has made great strides. We've managed to get over 175 former world leaders and Nobel Prize winners calling for a People's Vaccine. We've got academics, experts, union, independent SAGE, and parliamentarians on board as well. And we've also mobilized the voices of affected communities from around the world, such as healthcare workers, COVID survivors, and vaccine volunteers. And we've already heard this evening how tackling pharmaceutical monopolies is a matter of solidarity. It's a matter of racial justice. It's a matter of saving lives. But even if the government didn't care about any of this, we've also heard how it's a public health imperative. Dr. Jeremy Rossman has already set out really clearly how leaving the virus to transmit in unvaccinated parts of the world just risks the emergence of a variant or a mutation that could easily be resistant to existing vaccines. And from an economic perspective, even the International Chamber of Commerce has said that the world is set to lose $9 trillion in lost income this year alone from vaccine inequality. Ultimately, this is about corporate power and the allies of the pharmaceutical industry inside our governments. And this is what we really need to challenge. We cannot leave a small handful of corporations to decide who lives and who dies. They've had this power for too long, and we need to take public control over medicines now. Thank you.
Thank you so much, Heidi. I'm just going to take over for a short while for Belle. And I'm sure she'll be back joining us in a second. Our next speaker requires very little introduction, and I'm delighted that to have the opportunity to introduce him. He's the former leader of the Labour Party and a good friend for the Zero COVID Coalition. That's Jeremy Corbyn MP. Jeremy's Peace and Justice Project is, of course, an advocate for a people's vaccine and for vaccine equity internationally. I'm sure Jeremy will explain to us what can be done politically in this country and internationally to achieve our aims. Over to you, Jeremy.
Thank you, Joshua, and thank you for inviting me on. And it's a real pleasure to share this screen with so many other wonderful people doing such fantastic campaigning work, not just in Britain, but all around the world. And thanks also to the Morning Star for giving it a lot of publicity. COVID has shown just how unequal the world is. And COVID has also shown just how greedy many people in the world actually are. When wealth inequality in this country has increased massively, the same thing has happened all over the world. And health inequality has been demonstrated for exactly what it is around the world. And so the words of the World Health Organization several years ago saying the only way to generally improve health around the world is by universal public provision of healthcare is absolutely right. It was right then, it's right now, and it's the only way forward for the future. And I'll come back to those issues in a moment. But the development of the vaccine was a correct response to a novel virus that appeared. And I'm very interested in the analysis of how the novel virus appeared, but also the way in which any virus can, of course, mutate, develop, vary, and we're going to see more and more variants coming along. Two things come from that. One is the vulnerability of some people and some communities because of pre-existing poor health, poor lifestyles, or simple levels of undernourishment and poverty, but also because of the need to provide a vaccine to deal with it. And so I strongly supported the development of vaccines and supported public investment in those vaccines. No problem with any of that. What I do have an enormous problem with is that when there's a global need and a global effort to develop a vaccine, the profits for that vaccine seem to be going largely to a small number of big pharma companies who are withholding the manufacturing ability from others around the world, when it would be quite possible to develop enough vaccines to vaccinate the entire planet, if that was what the policy was going to be. And so the call to end the patent exclusivity on this, to hand that patent over either to the World Health Organization or simply to say anyone that can reproduce it safely may be allowed to do so, seems to me a very, very important step forward and will help a much wider campaign about vaccine take-up as a whole around the world, but a much wider campaign about public health around the world. So I strongly support the principles of the People's Vaccine Campaign. But then we look at the maps that were shown earlier about vaccine take-up. It is obscene, the levels of inequality on it. What you see is a high take-up level, or high provision level, perhaps is more accurate, in Britain, the USA, most of Western Europe, and one or two other countries around the world. What you see is a near zero opportunity to get the vaccine in other countries, and a very rapid spread of the virus, particularly in India at the present time. And so it is about supply and it is about cost. Also, let's not forget there are 80 million people, as many as a population of a large country, who are refugees around the world, who 99% of whom have no access to any vaccine whatsoever of any sort. And so what we see laid bare before us is health inequality on a global scale. The poorest die, the richest countries and the richest people get a vaccine and have some reasonable chance of survival as a result of that. So our message has to be, firstly, that we want decent healthcare for all around the world. I absolutely admire the work done by Médecins Sans Frontières. I've seen their work in operation in so many places. But the health service of the poorest countries of the world should not rely on great organizations like Médecins Sans Frontières. They should have an economic regime that enables them to provide for the healthcare of the people that need it. And if ever there was a message about what global health inequality does for the health of everybody, it's got to be this. Ebola is an example where a great effort was made to try and control Ebola, and it appears to have been largely successful. I want the same kind of effort put into challenging and dealing with COVID and COVID variants that exist around the world. The message surely has to be investment in our public health services. In Britain, we have a National Health Service, and I'm very proud of the principles behind the National Health Service. What I'm not proud of is the Health and Social Care Act of 2012 that allows privatisation within the service. What I'm not proud of is that the NHS is restricted from manufacturing its own medicines, its own pharmaceutical medicines. And so I was proud to put forward in the last general election a policy proposal, which was the NHS would set up its own pharmaceutical drug manufacturing capacity to manufacture generic medicines at cost for provision to the National Health Service. And of course, they could be exported as well under exactly those same provisions. But this is, I think, a turning point. It's a turning point because millions around the world have suffered and died when they need not have done, and it could have been prevented. It's exposed what health inequalities are about, and it's shown the obvious human need, the obvious need for improving the health quality of service to millions around the world. That means publicly run and publicly owned national health services. We are going to be challenged on a lot of this by Big Pharma. We're going to be challenged on a lot of this by those that make a great deal of money out of health inequalities by selling very expensive drugs to those that can afford it. South Africa won its battle eventually on antiretrovirals. India has developed a massive drug manufacturing capacity, as has Mexico and a number of other countries. But we cannot allow the big pharma companies that at the moment control the patent for the vaccine to control its supply in the future. That really is what the patent debate and argument is all about. And I was very pleased when President Biden announced that they would support a waiver in the case of the USA. I haven't heard the same statement from the British government. I'm not terribly surprised by that, but we will keep on demanding that. And Zero COVID campaign will keep on doing that. And my project, the Project for Justice and Peace, is not designed to undermine or take over anybody else's campaign. It's designed to unite and support people, which is one of the reasons why I'm on this call tonight, to unite people and support people around this campaign. We will conquer ill health. We will conquer contagious diseases. We will conquer disease if we work on the principle that everybody's life should be protected. If we work on the principle to protect inequality around the world, then the death rates amongst the poorest and the most vulnerable will continue to be disgustingly high, whilst the wealthiest countries, and particularly the wealthiest people in those countries, are able to survive. There's no shame in saying any of that. It's what we've got to be saying and doing all the time. Huge thanks, Joshua, for chairing this part of the programme, and to Belle, who's off voting at the moment in Parliament. Belle does a great job voting for all of us because she's my proxy voter in Parliament, because I'm not supposed to go there because I might catch or spread COVID when I go there. So Belle is doing it for all of us, as she does so many other guys. And to everybody else on the call, thank you so much for the great work you do and the hugely informative contributions that we made this evening. I've learned a lot from this call this evening. Thank you, Joshua.
Thanks, thanks, Jeremy, and trust me, the pleasure's all mine. Totally agree with you that Zero COVID Coalition and the Peace and Justice Project are partners, not competitors. Speaking of the Zero COVID Coalition, our next speaker is one of the co-founders of the coalition. We're going to Ben Chaco, editor of the Morning Star. And the Morning Star is a stalwart of our campaign, which has strongly supported it, along with Diane, the co-conveners, as I said. I'm hoping Ben will bring an international and internationalist perspective to the global fight for a people's vaccine, building on some of the things Jeremy said. Thank you.
Thanks very much, Joshua, and thank you to everybody. What a privilege to speak after such distinguished experts this evening. I've learned a huge amount, and thank you very, very much to all the other speakers for that. It can seem in this country that the pandemic is over. That's certainly the mood I detect among many of my friends. We're coming out of lockdown, we're coming into the summer, and everybody's quite happy about that. But we only need to look abroad to understand that this is emphatically not the case. In developing countries like Brazil and India, as we've heard, the virus continues to spread rapidly and kill thousands. There were over 4,000 new COVID deaths recorded in India on Sunday. Argentina has just gone into another national lockdown. We've heard from speakers tonight about the risks in huge parts of the world where vaccinations have not reached most of the population. As the concerns over the spread of the Indian variant show, this is of direct relevance in Britain. While coronavirus continues to spread, it will continue to mutate. New variants will be imported and re-imported to this country. We have no guarantee that our vaccines will be effective against them all. No decent person could observe the suffering and death in countries like India and not want to do all we can to help. But we also have, as Belle said at the very beginning, we also have a common interest in the global suppression of the virus. That's why the push for an international waiver on COVID vaccine patents is so vital. The measure was first proposed by India and South Africa last October at the World Trade Organization, and it was supported by almost the entire developing world very, very quickly. This month's support has spread among rich countries, as we've heard, most dramatically with Joe Biden calling for the patent waiver at the start of the month. Given the aggressive role of the United States in pushing for international recognition of medicine patents and successive trade treaties, this was a hugely significant U-turn. Because Biden's decision was quickly followed by France and Russia announcing support for the same thing, and China had already announced support, this leaves Britain as the only country on the UN Security Council which has not announced support for a patent waiver. There are some other powerful refuseniks, most obviously Germany and the EU, but our isolation is stark, and it really shames this country in the eyes of the world. Labour has been right to call on the government to get off the fence on a vaccine waiver, but we have to build that into a political movement to force a new policy on our government. The US's recent shift to donating more vaccine doses to developing countries and backing the patent waiver is linked to geostrategic considerations rather than humanitarian motives. It's US government sources openly say the drive is part of efforts to counter what they call vaccine diplomacy by Russia and China. In the immediate term, I don't think that's particularly important. The priority is to get the World Trade Organization to waive the patents and all of the countries where the pharmaceutical companies are based to enforce that. Why that decision is made is less important than it happening. But we should be aware that political rivalries have led various countries to scaremonger about each other's vaccines in a way which hasn't been at all helpful. And the US shift being tactical and short term means that we need to go further and push for a wider reckoning with big pharma. Even supporters of the patent waiver stress that it is a temporary measure for emergencies, but I would argue that the emergency exposes a much deeper problem with big pharma's control over medicines internationally. Big pharma's stranglehold on medicines is not a new problem, but it is a worsening problem. Patent rights are increasingly written into international trade treaties, such as last year's free trade deal between India and the United States. They even affect medicine access in rich countries. The Canada-EU trade deal was predicted to raise the cost of drugs in Canada by between 6.2 and 12.9%. Neoliberal domestic policy accelerates this process. India has steadily narrowed the definition of essential medicines over the recent decades. And in the Indian health system, essential medicines are medicines that India reserves the right to produce in violation of international patents, while it respects patents for ones which are not considered essential. So the fact that there are fewer essential medicines each year every time that they review their list means that the price of medicine is going up for people in that country. This is part of an international trend driven by the advance of neoliberal politics since the 1980s. It has weakened many countries' ability to respond to health emergencies. Commercialization has also affected public trust in vaccines. Britain has shown excellent vaccine take-up overall, but the higher levels of vaccine refusal among ethnic minority communities do reflect low levels of trust in the British state, and they are encouraged by conflicts of interest. As someone in the Q&A has asked speakers to confirm that they're vaccinated, I would emphasise that while we shouldn't trust the Tories, we can and should trust the NHS, and I know I'm really lucky to have received my first dose of the vaccine the weekend before last. We need a global vaccine rollout that matches the successes that we've seen in this country, and the testimonies Heidi mentioned are eloquent proof of that. The intellectual property argument that big pharma needs to guarantee itself huge profits in order to fund innovation is built on a lie, that pharmaceutical companies need these huge profit margins. Yet the industry spends far more on marketing than it does on research. Nor does the argument acknowledge the enormous role played by publicly funded scientific research in developing medicines. As a powerful article by a much-missed socialist and peace campaigner, Mike Marcuse, who wrote for the Morning Star about his own treatment for blood cancer, the article's called Held Hostage by Big Pharma. As that article points out, the corporate research model is recent. Publicly funded universities and hospitals have historically played a much bigger role in research. And it's also deeply problematic because the imperatives of competition between pharmaceutical companies put a brake on the sharing of information, which is the basis of scientific advance. Often private sector power is leveraged behind the scenes to mask the role played by public institutions, as when Bill Gates intervened last year to block plans for the vaccine being developed by Oxford University to be open license, using his clout as a major donor to the university's research to ensure rights to produce it were assigned to AstraZeneca. No surprise that Bill Gates is now among the most prominent opponents globally of a vaccine patent waiver. Gates's huge funding for healthcare around the world, for the World Health Organization, for medical research at Oxford is no doubt extremely generous. But as we can see, this philanthropic model comes with a cost. It's unaccountable, and we leave rich people making the decisions on who accesses the results of that research and how. The scale of this crisis internationally does, however, make it an opportunity for change. The case for breaking the power of big pharma is being made daily, as is the case for tearing up the cloying web of corporate treaties that undermine democracy and national sovereignty the world over. Tackling a health crisis of this magnitude means asserting democratic control of the response. The corporate right to make a profit cannot be allowed to trump that. Thank you.
Thanks, Ben. Really appreciate your contribution as always. We're doing quite well for time. We have two more speakers left. Our next speaker is Jonathan Schmidt-Dermine. Please tell me if I've got that right. A leading member of Zero COVID and Zero COVID Alliance, operating in Germany, Austria, and Switzerland. We've already heard today about the German government's position. It's one of the leading countries in Europe, which is opposed to a vaccine patent waiver. Jonathan will hopefully be telling us about the campaign to change that and the process of building a cross-border zero COVID campaign. Over to you, Jonathan.
Yeah, thanks a lot. Let me start. The pandemic affects everyone, but not everyone is affected equally. Dependence on labor under conditions of exploitation, economic insecurity, precarious living conditions, lack of access to medical treatment in your country, threats of domestic violence, disabilities and medical conditions, or living without papers makes people more vulnerable, not to speak of those people living in war zones and regions of humanitarian crisis, like the Yemen, Tigray, or Kurdistan. Through the lens of the pandemic, these horrific inequities became more evident than ever. However, the pandemic also taught us something else. If we want to take the task of global solidarity serious, we cannot restrict ourselves to merely seeking some limited remedies for these inequities. The pandemic makes us aware of a global systematic interconnectedness, which proves even the most well-meaning European attempts at compensating for global inequities to fall short of the particular responsibilities of the rich European countries in this world if they do not take into account their very own vulnerability and dependency. Let us go back 1 year ago. At the beginning of the pandemic, it were the rich countries of Europe and the US, those arrogantly deeming themselves the best prepared for the pandemic, which were among those hit the hardest by the pandemic. Relying on their intensive care units and later the deployment of tests and now the deployment of vaccines, they ignored the calls for implementing a zero COVID elimination strategy based on comprehensive non-pharmaceutic measures and did not even discuss the goals of their strategy. Those voices in Europe who at the beginning of the pandemic, including myself, I have to say, primarily warned about not to turn a blind eye on the conditions in countries with poorer medical and economic infrastructure, while being self-assured about the preparedness of Europe, turned out to be short-sighted. The same holds for those who primarily warned against the consequences of lockdowns in rich countries for global supply chains, for those dependent on precarious, undocumented work or on remittances of expats, up to the consequences for world hunger. While these issues are very real and still need to be addressed urgently, they became only much graver due to the inevitable, repeatedly imposed and inconsequently implemented lockdowns and further restrictions, which followed only short-term interests of certain dominant parts of economy, including especially industry in Europe. Now, over 1 year later, the European countries and the US have failed to combat the pandemic and have put all their hopes into vaccination, soon to arrive, letting millions die till then. Meanwhile, they allowed virus variants to emerge, which are now plaguing India, Nepal, Colombia, Central Asia, and so on more severely than ever. In many rich countries, the epidemic is only under control to a certain degree because the vaccine doses available there are missing in the rest of the world and needed there. But of course, they would also be needed in the rest of the world as a precondition to prevent the pandemic from coming back after having been sufficiently contained. We thereby understand how the struggles for a zero COVID strategy and for vaccine equity necessarily belong together. As long as rich nations do not get convinced of a clear anti-pandemic strategy aiming at elimination, the struggle for vaccine equity will have to resort to weak appeals for charity. On the other hand, an equitable and comprehensive distribution of vaccines is necessary to end the pandemic everywhere, to prevent the creation of further variants and further waves of the pandemic, even in the rich countries. For these inequities, no remedy will be found as long as we restrict our perspective on the distribution of vaccines. The plan to ensure equitable distribution by the joint efforts of the wealthy countries, the COVAX program, turned out to be a big deception. Even its envisaged very limited effectivity is put into question by export restrictions, bilateral exclusive vaccine deals, and the epidemic escalation, especially now in India. Even more, of course, the fundamental problem is also not that some singular small countries like Chile, Israel, the Emirates, or the Seychelles can secure exceptionally rapid vaccination programs and thereby provide model cases for herd immunization, or that in some particular cases, singular acts of sharing vaccines might have been more advantageous for all sides. The unequal distribution, in fact, is a mere result of the run for buying vaccines heated by the principle of international competition of nation states on the one side, and the limitations on global production capacities caused by the monopolization of vaccine technology based on patents, trade secrets, market power, and political power. We cannot build vaccine equity and on charity, and especially now, as it becomes evident how the rich countries have failed living up with their promises for treating vaccines as a global public good, it shall now be our minimum demand that all barriers shall fall which prevent developing countries from producing vaccines, but also tests and protective equipment themselves, and to take the destiny into their own hands. And these, our minimum demands really shall be waiving patents and then sharing technologies. More specifically, especially the capacities for mRNA vaccine production in developing countries, but also in developed countries, remain unused, while more licenses comparatively for whole virus vaccines and virus vector vaccines have already been deployed. The mRNA vaccines could play a key role in ending the pandemic. They are safe, highly effective, easy to produce, even in a wider range of production sites with less safety requirements, and they are very quickly adjustable to new variants. We cannot leave these tasks to the interests of monopolies, which will only expand production with new partners to such an extent that it will guarantee short-term extra profit. By supporting the WHO proposal for an mRNA COVID-19 vaccine technology transfer hub, technology would be transferred in a safe way, quality would be guaranteed, and the expansion of mRNA vaccine production would be considered then as a global task and not as a task for some monopolies. I was asked to say a bit on the situation in Germany. Now I haven't prepared so much on that, but of course now the eyes of all the world are of course on Germany, because they are blocking the patent waiver in the WTO, and we really have to push, I think, on one thing, namely. Germany primarily argues, of course, on the one hand ideologically, but on the other hand with their advantages in the international economic competition. They really want to build their future economy on monopolies on mRNA technology, and so they are opposing both the sharing of technology and also the waiving of patents, even if it's also ideological and some are very unfounded, but however. And if we want to make the production of vaccines a global task, we should really break with this principle of the international competition of nation states. It's not only about the companies, it's also about the nation states. Just my appeal at the end, let us put the collective efforts of human creativity and the products of labor, the pharmaceutical research, development, production, and deployment into the service of global health and scientific progress instead of monopoly profits and national economic advantages. This would be it. I think these were 8 minutes. Thanks a lot.
Ready. Thank you, Jonathan. Really appreciate your contribution. If we want to make vaccination a global task, we must end the competition between nations, I think you said, and that's really, really important. Our final speaker, Dr. Rita, is it Rita? Moran, except my apologies if I didn't get that quite right. Dr. Moran is our final speaker this evening from the Status Now network. we've had a wide-ranging discussion this evening, which I've enjoyed. I hope you've all enjoyed it as well. And we've talked about things like vaccine hoarding, the problem of patents and unequal distribution of vaccines. But we also have this problem of injustice within countries, which a few speakers have also touched on. I'm hoping that Dr. Moran will speak to us tonight about barriers to accessing vaccines within countries, mostly really talking about undocumented people. Thank you. Over to you, Dr. Moran.
Thank you. It's Retta Moran. Thank you very much indeed. And thank you very much for inviting me to be here with you on behalf of the Status Now Network. And thanks to the other panelists for your information sharing throughout this meeting. And I want to first echo that call for global solidarity that Jonathan's just made. And I'm struck really by the extent to which it is the Western governments, the rich governments, who have in fact been relatively the best prepared to develop responses, who actually themselves have been instrumental in the formation of the economic relations and the social relations that come from that actually created COVID-19. And I'm speaking to you from the birthplace of the Industrial Revolution. I'm speaking to you from the city of Manchester in the north of England, and that's the basis upon which I'm observing what I'm saying now. And the other thing I'd like to say at the beginning is we all know that COVID-19 would not exist if the poverty and discrimination did not exist. Just as we know that as human beings, we are capable of mapping our territory and planning from that mapping. We can uncover where a territory or an environment is dangerous. We can work out why it's dangerous. We can understand and communicate the optimum actions to be taken to end that danger. And in the UK, this ability dates from the cholera outbreak in Soho in London in 1854, when John Snow plotted the incidence of death in a street map of the area and concluded that a pump of water was infected with feces from a nearby cesspit. His methods contributed to the advent of germ theory and identified the spatial distribution and transmission of the disease, even if its original cause remained unknown. And his methods have been part of fundamentally underpinning modern epidemiology and preventative healthcare ever since. However, his methods, and every method developed since, is entirely dependent on what can be seen, on who becomes entered as a statistic, and who remains uncounted. And one of the groups in the UK and around the world who are being left out of the counting and everything else is the undocumented people. And in the UK, it's difficult to know what the figures are, but the figures are ranging up to 1.5 million people. Now in March last year, March 2020, as soon as COVID-19 lockdown was announced, people without status, as in people without indefinite leave to remain in the UK, and those working shoulder to shoulder with them, knew that they were going to be immediately at a very significant disadvantage for lots of reasons, including, and all of this that I'm going to list is about the absence of infrastructure, public infrastructure. Having barely enough money to eat, never mind keep healthy and therefore more likely to become sick, being without a home or living in very overcrowded accommodation and therefore not being able to self-isolate if sick or protect oneself and each other if someone else at home gets sick, working a job that's under the radar and therefore doesn't offer any protection whatsoever in terms of wage or being furloughed during lockdown or basic health and safety, not being able to access a doctor or a hospital or a test or vaccination site because of not believing that my data will not be shared with bodies who will report me for not having status and then expose me to the risk of detention, removal, or deportation. So because we knew this, the only way that we could see for people without status to protect themselves, each other, and everyone around them was to offer a way for the state and the government to communicate with undocumented people and our networks of allies. And the Status Now network is unique in that it has brought together people who are undocumented right the way through to people who tomorrow, maybe, will get a notice telling them that they've got some kind of refugee status. We put the call out on the 27th of March last year. We wrote to the Prime Minister of the UK and the Republic of Ireland because we understood that undocumented people and those in legal process are an essential part of creating a public health response to COVID-19, and that applies around the world. And they are an essential part of doing everything that is necessary, and again, this applies around the world, to both stop people becoming infected and to stop people from passing it on. And of course, prior to this time in the UK, there was very much a sense of being in the shadows as undocumented people, without rights and open to being exploited and oppressed because of not having those rights. So the Status Now network has come into existence in order to enable a visibility so that all of you on this call can connect with the undocumented people who are part of the solution in the UK and around the world. Many of these people are qualified to work in essential services. Many can and do work. Many people have died already, but they're not necessarily counted. We know of several people who have gone from being in an environment, probably an overcrowded environment, in a multiple occupancy house, who have died, who have gone straight to mortuaries and straight to crematoriums. And their figures are not represented anywhere. They're just not figuring at all. Many of the people who are undocumented are Commonwealth citizens, are here directly because of the UK's foreign policy, both in the past and up to the present day. And because people do and continue to come to the UK and they move around the world. The figure has been raised of 80 million displaced people around the world. People have moved here to survive. And those people are part of the solution alongside everyone else who is here today to be part of that future that is worth living for all of us. Now, I'd like to just turn to some of the points that were raised by the speakers as the last speaker. So I thought it might be good to just re-echo some of the things that have been said. And Richard kicked us off. He talked about a perilous syndemic. And it's a syndemic. Why? Because actually it's underpinned by poverty. It's underpinned by already having a very suppressed immune system. This, if you're in a rich Western country, this is going to settle into those pockets of horrible poverty. And those pockets are becoming bigger and bigger and bigger because of the way in which our infrastructure is being destroyed. Masaka told us that our survival as a human race means that not one group can be left vulnerable. And Juan talked about vulnerable people, those last in line when it comes to getting any healthcare. And we in the Status Now network have been working with women who are undocumented, who've had babies during COVID and who've had nothing to support and enable them during that process. And where the state has been aware of those women's existence and still failing to intervene to help them. Heidi told us that the vaccine is a private asset. And that struck me because we can see now in the way in which the world is talking about how the world is going to move forward from this point, travel itself, as opposed to forced migration. Travel itself is becoming an extremely privatized commodity. And this is being concentrated in Britain with something that Privacy International exposed in its report that was published in February, called the Status Checking Project, where the government is investing in private companies to develop a system where it will be possible, theoretically, and presumably this is what they want, to be able to check everybody's status when they touch a screen. Now, if you don't have your status, where does that leave you? And there are horrible, horrible echoes here of the ways in which information technology is being applied to effect deeper and deeper discrimination. It's information technology that produced the lists that got put on the notice boards during the Second World War, telling people in communities who had to get on the train the next day to go to a concentration camp. Depending on who's in control of that information technology, in the same way as who is in control of the production and the distribution and the access to vaccine, but not just to vaccine, to track, to test, to trace, to isolate, to quarantine, to vaccine, to healthcare. And unfortunately and tragically and obscenely, if people are undocumented, their risks associated with this become exponential. So public control over the whole set of processes is absolutely essential. And in order for that public control to evolve, I really want to make the plea for everybody here and all the networks that you have to embrace the Status Now network and to help us to become more involved nationally and internationally, so that the voices of people who are undocumented come through. I don't usually speak for Status Now. In fact, this is one of very few times where I have spoken, but there's a wealth of people involved in the network throughout the UK and in Ireland who can speak for themselves, who can tell you themselves exactly what's wrong with the way in which the world is being organised right now. And therefore, I would call upon you to embrace those undocumented people. And when Belle began, she talked about needing a combination of compassion and common sense. And Jeremy talked then about that obscene disparity in the vaccine take-up. We are at a turning point. We are at a turning point. And everything that I've heard from everybody on this call, on the one hand, makes me wonder how I'm going to walk away from this call to people who, if I walk down on my street, just are so frustrated and so upset by everything that's happened and want to kind of try and forget it now and try and get on and get back to normal. That's the thrust. So the way in which the message is evolved is so vital now. And I'm very, very glad that you asked the Status Now network to come. Very glad to meet you all, and hope that this is the beginning of an ongoing dialogue, because that global solidarity is what is going to win. The end of private processes right the way across the board and right the way through the world. And the only way we can do that is all together. Thank you.
Thank you very much, Dr. Moran, and thank you so much for speaking out for the undocumented. There are far too many people, I think, who don't in this day and age, at a time when increasingly divisive arguments are taking over our politics. I think it's so important to insert that in every single thing that we do. And thank you so much to Josh, who took over chairing. My apologies, I was actually also meant to speak in another meeting, but the main thing that happened is I had to run off and vote because the finance bill finished. Some sessions of the finance bill finished early because apparently people aren't interested, and so some of the parliamentary speakers pulled out. Completely different subject, but thank you so much to all of our speakers today from right across the world, bringing perspectives from right across the world and showing just how truly global this movement is, because the pandemic is global and we're only going to eliminate the virus if we work together. So many of our speakers have touched on a range of different things, and I'm so glad that this has been recorded. I was listening as I was running along, but no doubt I missed a few bits as I was panting through the lobby. So I look forward to listening back to some of those. But the Zero COVID Coalition continues to campaign for a zero COVID policy right across our country, right across our world, with the global zero COVID movement, and working with people's vaccine campaigns right across the world as well, making sure that people understand just how crucial it is to protecting global populations, that we do end vaccine nationalism, that we do look at making sure that there are vaccines available for everybody, and that we stop these really disgraceful arguments as to why we cannot release patents, as to why countries in the global south, which already have major capacity to make vaccines, shouldn't be allowed to do it. Everybody has to be protected. Until we are all safe, none of us are safe. So thank you so much to all of our speakers. Again, please do make sure that you are following the Zero COVID to find out about our next meeting, which are always so wonderfully attended. And I look forward to seeing you all on our next call. Thank you very much. Have a good evening.
Thanks, Belle.
Thank you.
Thanks, everyone.
Thank you very much.
Thank you. Thank you, everyone. Really interesting. Very good discussion.